Yesterday we started discussing on liver cirrhosis. These are the functions of liver. This is the definition of liver cirrhosis. That is replacement of normal liver tissue by reduced cirrhosis and simultaneous formation of regenerative new liver. So it is fibrotic shrunken liver. Liver cirrhosis means it is a fibrotic shrunken liver which is non-functional. These are the types of cirrhosis: lipotic cirrhosis, post-necrotic, biliary, and cardiac. These are the four main types of cirrhosis. This is the pathophysiology. The initial insult is necrosis of hepatocytes, collapse of the normal lobular architecture of the liver, intrahepatic shunting of hepatic artery and portal vein, mixing of blood occurs, because of which there is portal hypertension. Then this necrosis followed by healing process. Healing process is always by fibrosis and scarring. The ultimate result is small fibrotic shrunken liver or a scarred liver. These are the stages of liver. A healthy liver initially start fatty changes, deposition of fat, later on liver fibrosis, and then it progresses to cirrhosis. So these are the various causes of liver cirrhosis. Mostly, or in our setup, or in our India, the most common causes are alcoholic hepatitis, viral hepatitis, and chronic biliary obstruction. These are the most common causes. First three. Now the manifestations of liver cirrhosis. It is a very insidious, slowly progressive disease. So early manifestations are very vague. Patient usually presented with fatigue, anorexia, abdominal dyspepsia, indigestion problem, etc. So initial symptoms are very vague, or symptoms are invalid, or symptoms mainly related to GI. And later on, the manifestations are mainly because of complications of liver cirrhosis and due to loss of function of liver. These are the various manifestations in liver cirrhosis. Neurological manifestations, gastrointestinal manifestation, reproductive manifestations are mainly because of increased estrogen level in body because estrogen cannot be metabolized by failing liver. Cardiovascular, there is circulatory collapse, patient in shock, metabolic, hematological, and integral. Now these are the various manifestations in liver cirrhosis patient. Can present with purpura, vertice, spider angioma, gynecomastia, enlargement of breast veins, jaundice. This is palmar edema. This spider angioma or spider neva and palmar edema is mainly because of estrogen level. And this is the acute vertice, dilated abdominal veins. Investigation is mainly to find out the cause of liver cirrhosis because liver cirrhosis is not a primary disease, it is the end result of chronic liver disease, whatever be the cause. So you have to find out the cause of liver cirrhosis. So to find out the cause of liver cirrhosis and to see its complications, the investigations are aimed mainly towards this. So the basic investigations: first liver function test. No doubt you have to see first liver function test or how your liver is working now, or to what percent your liver is working now. So when liver cirrhosis is there, liver stop all its functions, so that in liver function test you get low albumin. Albumin cannot be synthesized by the liver. Bilirubin sometimes raised, liver enzymes sometimes raised or can be normal because of necrosis of all liver cells. Once there is necrosis of all liver cells, no enzyme production by the liver cells, so liver enzyme can be normal. Then complete blood count, you get low hemoglobin, patient is anemic, iron deficiency as well as vitamin B12 deficiency, but megaloblastic anemia is more common. Then low platelet and neutropenia. Blood sugar level is always low because it is the main storage organ or main organ for glycogen storage. Clotting time, bleeding time increase because clotting factors are not synthesized by the liver. Platelets production is also less. So prolonged clotting time, bleeding time, prothrombin time. Then you have to find out the cause, and for that you have to do the viral markers. Whether the cause of liver cirrhosis is viral hepatitis, particularly hepatitis B and C, and for that the investigations required are surface antigen and SCP. Then the imaging studies like ultrasound, CT scan, you can know the status of liver. Liver biopsy is an invasive investigation if you are not able to find out the cause of liver cirrhosis. And blood ammonia level, ammonia is the toxic product of liver body of protein metabolism. It is the product of protein metabolism which is detoxified by the liver, converted to urea. But if there is liver cirrhosis, your liver is not able to convert this ammonia to urea, and urea is then excreted in urine. So that in liver cirrhosis, blood ammonia level is increased. And this increased blood ammonia level hampers your brain functioning, and that results in hepatic encephalopathy. Then MRCP, ERCP is investigations to rule out obstructive jaundice. Endoscopy is done to see the dilated esophageal veins and the risk for hematemesis. The dilated esophageal veins can rupture anytime and result in hematemesis. Then portal vein Doppler to measure the portal venous pressure. The complications of liver cirrhosis are three major complications which are responsible for the mortality. Portal hypertension, which cause ascites and esophageal varices that results in hematemesis. Hepatic encephalopathy is mainly because of accumulation of toxic substances which are affecting brain functioning, and hepatorenal syndrome, that is deteriorating renal function causing renal failure. So these are three main complications: renal failure, encephalopathy, and portal hypertension. Other minor complications are anemia, patients having low immunity, so they are prone for recurrent infection. Bleeding tendencies, hypersplenism, enlarged spleen causes rupture of all cells, RBC, WBC, and platelet. That is called increased sequestration of cells by the enlarged spleen. Now, this condition is called hypersplenism. And this hypersplenism results in pancytopenia, decreased WBC, decreased RBC, decreased platelet. Then, patient of ascites. Patient with ascites more prone for peritonitis, which is called as spontaneous bacterial peritonitis. It is called spontaneous bacterial peritonitis, which is a very common complication in patients with ascites, SBP, spontaneous bacterial peritonitis. Then peripheral neuropathy. This portopulmonary syndrome results in breathlessness, liver cirrhotic patient complaining of breathlessness, and circulatory failure, patient presented sometimes in shock. That is the cardiac complications, circulatory failure. So all these are the complications of liver cirrhosis. The remaining part is treatment part. Treatment is always supportive. Once your liver is shrunken, fibrotic, become non-functional, there is no treatment to save the liver or to regenerate the liver. So the treatment is always supportive and treatment of complication. So treatment is supportive plus treatment of complication. So first your aim is to remove the positive factor causing liver cirrhosis. High protein diet, as these patients are anemic, hematinic, vitamin B12 supplement. Then this patient usually presented with ascites, so treatment of ascites we will discuss later on. Then treatment of portal hypertension. For portal hypertension, the drug used are vasodilators, mainly the isosorbate dinitrate, mononitrate, or carbidiol, a beta blocker. These are the drugs preferred in portal hypertension. Vasodilators, they decrease portal pressure and they decrease the chances of hematemesis. So treatment of portal hypertension with beta blocker and with nitrates. Then treatment of varices, if there are dilated esophageal veins which can rupture and can cause hematemesis, then the treatment of the dilated veins is mainly sclerotherapy or banding, keeping a band around them, or sclerotherapy. That is the treatment of esophageal varices, which is done with the help of gastroscopy. Then treatment of hepatorenal syndrome. Hepatorenal syndrome is actually there is no structural damage to kidney. It is the functional deterioration of kidney function. There is no structural damage to your kidney. It is the functional deterioration because of decreased blood supply to your kidney. It is mainly because of decreased blood supply to kidney. And so for that, your aim of treatment in hepatorenal syndrome is to improve the blood flow to the kidney. And to improve the blood flow to the kidney, you have to do albumin. Then vasoconstrictors like vasopressin. So treatment of hepatorenal syndrome mainly include albumin and vasoconstrictor-like vasopressin, which raise the blood pressure and improve the blood flow to the kidney. So, albumin and vasopressin. Then antibiotics if there is spontaneous bacterial peritonitis. Then treatment of encephalopathy. If patient in hepatic encephalopathy, patient is disoriented, irritable, confused, excessive somnolence, having flaps, that means patient in hepatic encephalopathy, or sometimes patient presented directly in coma, directly in unconscious state. So your main treatment is to remove the toxic substances from the body, because it is mainly because of accumulation of toxic substances. So you have to remove these toxic substances with the help of laxatives. Patient should pass 5 to 6 motions per day. You have to clear the gastrointestinal tract of the patient to remove all the toxins from GIT. For that laxative, the preferred drug is lactulose or bowel gross or bowel enema. And then antibiotics to sterilize GIT. Antibiotics to sterilize GIT. The preferred antibiotic to sterilize GIT is neomycin, which is active locally. That is neomycin. So treatment of encephalopathy is to remove toxic substances with the help of laxative, that is lactulose, bowel wash, and antibiotics. Then vitamin K and fresh frozen plasma transfusion if there are bleeding tendencies. Vitamin K and FFP, because there is deficiency of clotting factors which are used in extrinsic pathway. So fresh frozen plasma provide you the clotting factors and vitamin K. Then liver transplant, that is the last option in liver cirrhosis. The last option is liver transplant. So this is the treatment of liver cirrhosis. Supportive plus treatment of complications. So this completes your topic on liver cirrhosis. There can be a long question in theory and there is a long case. There is a short case actually in practical. No long case in case of GA. There is a short case. Now we discuss in detail about ascites. It is the most common presentation in patient of liver cirrhosis. Distension of abdomen. Patient usually present with this type of abdomen. It is nothing but it is the fluid in peritoneal cavity. This distension is mainly because of fluid in peritoneal cavity. What is ascites? The definition: the accumulation of excess of fluid in peritoneal cavity. There is little amount of serous fluid normally in the peritoneal cavity for lubrication purpose and for the movement of your abdominal organs. Ascites is clinically detectable when the fluid volume exceeds 500 ml. But on UHG, on ultrasound can detect even smaller ones. So it is nothing but excessive accumulation of fluid in the peritoneal cavity. So this fluid is of two types again, as we discussed in pleural effusion. It is of two types, transudate and exudate. The causes of ascites for transudate and for exudate. The most common cause of ascites is liver cirrhosis, and it is a transudative type. Next is congestive cardiac failure, renal failure, and hypoproteinemia. These are the causes for transudative type of fluid collection: liver cirrhosis, congestive cardiac failure, renal failure, and hypoproteinemia. For exudate, infectious causes and malignancies. So infectious causes, the most common infection in our India is tuberculosis. Tuberculosis peritonitis can cause exudative type of ascites. Then pancreatitis and malignancies, either primary or secondary. These are the causes for transudative type of ascites and causes for exudative type of ascites. Pathogenesis is again same as we discussed in edema. So accumulation of or this excess accumulation of fluid in the serous cavity is mainly because of four mechanisms. These are the four mechanisms. One is increased hydrostatic pressure. Second is reduce oncotic pressure or the colloid osmotic pressure, which is mainly because of proteins or mainly because of albumin. So increase hydrostatic pressure, decrease oncotic pressure, disturbances in capillary permeability, or there is damage to capillary wall or increased capillary permeability, which causes fluid to come out from the vessels into interstitial spaces, and insufficiency of lymphatic drainage or obstruction to the lymphatic drainage. So these are the four main mechanisms behind excess accumulation of fluid. In case of ascites, 85% of patients the cause is liver cirrhosis. And then other causes contributing less. Peritoneal malignancies, heart failure, tuberculosis, pancreatitis, Budd-Chiari syndrome, and renal failure or nephrotic syndrome. So these are the other rare causes: nephrotic syndrome, pancreatitis, Budd-Chiari syndrome, tuberculosis, heart failure, and peritoneal malignancy. But 85% of cases it is the liver cirrhosis. In clinical manifestations or the clinical presentation of patient, as we discussed, the most common presentation of patient is distension of abdomen, gradual distension of abdomen, then swelling more loudly, then breathlessness, and others. Others like fever, abdominal pain, anorexia, all these are depending on underlying cause. The clinical presentation, distension of abdomen, edema over the doorway, breathlessness, and others depending on the cause of ascites. Now examination of patient, general examination is for abdomen examination. On general examination, again depending on underlying cause. If the underlying cause is malignancy, underlying cause is infectious, then you have to see the enlarged lymph nodes. Because in malignancy, in tuberculosis, you get enlarged lymph nodes. So whether there is lymphadenopathy present or not. If the cause is hepatitis or liver cirrhosis, you sometimes get elevated bilirubin and that produces jaundice. So whether there is yellow discoloration present or not, associated jaundice. Then there is increased respiratory rate because patient is breathless. Blood pressure can be normal. Pulse rate can be increased. Edema is present, no doubt. If the cause is renal failure, you get puffiness of face also, or periorbital edema. If the cause is renal failure or nephrotic syndrome, then patient is anemic, so you get pallor on general examination, and other signs of malnutrition. Other signs of malnutrition. So positive finding on general examination: patient conscious oriented, but if patient is encephalopathy, not conscious oriented. Patient can be febrile or febrile. Vital parameters: increased pulse rate, blood pressure can be normal, increased respiratory rate, pallor is present, edema is present, lymphadenopathy can be present if the cause is malignancy. You get puffiness of face if the cause is renal failure. So these are the positive findings on general examination, depending on underlying cause. Now abdominal examination: inspection, palpation, percussion, and auscultation. 4 points. In inspection, actually we will discuss in detail in practical also these points. Just note down. In inspection, you get abdomen is distended. Because of distension of abdomen, your umbilicus gets stretched, which is called as laughing umbilicus or smiling umbilicus. Gets stretched transversely. The distance between umbilicus and zipisternum is more than the distance between umbilicus and cutis symphysis. Flanks are full. Nearly 1500 ml of the fluid is required to make the flanks full. There are dilated veins over the abdomen. If scrotal edema is present, it usually indicates nephrotic. Palpation. In palpation, you have to first see whether there is any local tenderness present or not. If there is bacterial peritonitis, if the cause is exudate or because of infection, you get tenderness, local rise of temperature. Then rebound tenderness if there is peritonitis, doing feel if it is tuberculous peritonitis. If it is liver cirrhosis, you get enlargement of the spleen, that is splenomegaly. Then, if the cause is congestive cardiac failure, you get enlarged liver plus ascites. So palpation includes local tenderness, palpation of liver and spleen, and whether any abdominal lump or any swelling is palpable. So palpation include tenderness, palpation of liver and spleen, and other abdominal swelling. So percussion is important here. There are two important tests to diagnose ascites. One is shifting dullness and second is fluid free. We will discuss in practical detail what is shifting dullness, how to do, and what is fluid free and how to do. So in percussion, these two tests are very important to diagnose ascites. Shifting dullness is an important sign of free fluid in the cavity, and it requires near about 500 ml of fluid to elicit this sign. Fluid is present in tense ascites only. Presently, tense ascites only. If the fluid is very small in amount, nearly 120 ml, then it is demonstrated by Pudal sign. So we will discuss in practical all these three signs: shifting dullness, fluid fluid, and Pudal sign. Pudal sign is not important for you. You just remember the name. If the fluid is small in amount, around 120 ml, then it is demonstrated by Pudal sign. But in practical, you have to demonstrate shifting dullness and fluid fluid in the case with ascites. In short case, you have to demonstrate shifting dullness and fluid fluid. So these two tests are important for you. Auscultation is not important. So these are the 5 classical physical signs to demonstrate ascites. You should know abdomen is distended, flanks are full. Then there is dullness in the flank, that is horseshoe dullness. Positive shifting dullness, fluid should present, and Pudal sign for small amount of fluid. So this is the minimum amount of fluid required. For Pudal sign 120 ml, for shifting dullness 500 ml, for fluid fit 1000 to 1500 ml. Ultrasound can detect around 100 ml of fluid. CT can detect around 100 ml of fluid. Now, once there is diagnosis of ascites, now your aim is to find out the cause of ascites. So, 85% of cases it is liver cirrhosis. But still, you have to diagnose or you have to find out the cause of ascites. Its cause should be determined by laboratory analysis. The important investigation is ascitic fluid study or the fluid analysis. So, for that, you have to do diagnostic paracentesis. Means you have to remove some 10 to 20 ml of the fluid from the abdomen for analysis. You have to send it to lab for analysis. And first, your aim is to decide whether it is transudate or exudate. And then causes according to that. If it is transudate, causes of transudate. If it is exudate, causes of exudate. So that is called as diagnostic paracentesis. 10 to 20 ml of the fluid is removed from the abdomen. The site is from the umbilicus to the right superior spine, the midline. In the midline between the pubic symphysis and umbilicus is rare site, but the most common site is umbilicus and anterior superior spine, the midpoint of that line. The midpoint of that line. That is the site for diagnostic therapy. These are the three sides. This is the right side, left side, center. But the most common site is this. Right side is the most common side. Umbilicus and anterior superior iliac spine. You have to draw a line from umbilicus to anterior superior iliac spine, and the midpoint of that line is the most common site to remove the fluid for diagnostic purpose, as well as for therapeutic purpose. So this is the report of fluid analysis. You have to send it to lab to decide whether it is transudate or exudate. That is fluid analysis. So what to see? The features are same as we discussed in pleural effusion. If it is transudate, appearance should be clear. Specific gravity should be less than 1015. Proteinuria should be less than 3 gram %. SAG. SAG we already discussed in pleural food examination also. SAG is nothing but it is serum albumin minus ascitic albumin. Is the difference in serum albumin level and ascitic albumin level. Gradient is nothing but a difference. Ratio is nothing but a division. Ratio is division. Gradient is difference. So serum albumin minus ascitic albumin, it should be more than 1.1 in case of transudate, that is called as SAR. This is the serum albumin ascitic gradient. Cell count should be less than 250. LDH level should be low. ADA, adenosine deaminase enzyme should be normal. Opposite to that in exudate, it is either straw color, bloody, milky, purulent, depending on the cause, but it is not clear. Specific gravity more than 1015, protein level more than 3%, SAB ratio less than 1.1, cell count more than 500, LDH level is high, adenosine deaminase level is high if the cause is tuberculous peritonitis. Other investigations like gram stain of the fluid, culture sensitivity, Zedian stain, then differential leukocyte count, all these are the other investigations. In differential leukocyte count, if there is neutrophil predominance, suggestive of acute infection. If neutrophil predominance, suggestive of tuberculosis. So this is the report of fluid analysis. You have to decide whether it is transudate or exudate. And also you have to see in cytology the presence of malignant cells to rule out malignant cells. Other investigations include X-ray abdomen, ultrasound, CT scan. These are the radiological investigations to find out the condition of liver or other causes. Blood investigation again same liver function test, kidney function test, complete blood count, serum lipase amylase to rule out pancreatitis. Serum lipase and amylase to rule out pancreatitis. So these are the investigation in case of ascites. The most important investigation is fluid analysis. Treatment is according to the cause. For transudate, for exudate, depending on the cause. For transudate, the treatment is mainly bed rest, fluid restriction, salt restriction, high protein diet, and the main drug use is diuretics. Main drug use is diuretics. Aldactone is the preferred drug because in liver cirrhosis there is activation of RAS system, that is renin angiotensin aldosterone system. This RAS system get activated. There is high ADH, that is antidiuretic hormone, high aldosterone level. So you have to give aldosterone antagonist. You have to give aldosterone antagonist as the treatment. So aldactone is an aldosterone antagonist. So the preferred drug in diuretics is aldactone. You can also use fusimide also. So the most important treatment for transudate type of ascites is salt restriction, bed rest, fluid restriction, high protein diet, and diuretics. And then therapeutic paracentesis. Therapeutic paracentesis means you can remove 1 or 2 liters of the fluid from the abdomen in order to give relief from breathlessness, because it causes breathlessness. Distension of abdomen causes patient to feel breathless. So to give relief from breathlessness, you have to do therapeutic technique. Therapeutic technique, diuretics, salt restriction. That is the main treatment in transudate. For exudate, depending on cause. If it is tuberculosis, anti-tuberculous drug. If it is malignancy, chemotherapy. If it is nephrotic syndrome, steroids. So depending on the cause. If it is exudate. If there is spontaneous bacterial peritonitis as a complication of ascites, you have to do antibiotic. In spontaneous bacterial peritonitis, the preferred antibiotic is third generation cephalosporin. The antibiotic which are preferred in SBP is third generation cephalosporin, that is cefotaxime and ceftriaxone is preferred. So this is therapeutic technique to remove 1 or 2 liters of the fluid from the abdomen so that patient get relief. So that is the treatment of ascites for transudate or exudate. Mainly salt restriction, diuretics, and therapeutic technique. So this completes your liver cirrhosis and ascites. So probably we will discuss next time about acid peptic disease.